Welcome to the deep dive. Today we're doing a high-speed, high-yield journey into a really critical area of medicine: inflammatory heart diseases. These are the conditions where, infections or even your own immune system can turn against your heart. We have a summary of the absolute essentials, the mechanisms, the causes, the buzzwords, everything you need to really feel fluent in this topic. So our mission is to unpack this dense material conversationally, making sure every key concept really sticks. And to do that, we're going layer by layer using the heart's own anatomy, the endocardium, the myocardium, and the pericardium as our guide. Because where the inflammation hits, well, that defines everything.
That structural approach is, I think, the only way to really get it. It makes it all click. If you can just remember what each layer does, you instantly understand what happens when it gets inflamed. We can even use a simple analogy. Think of the endocardium, which lines the chambers and forms the valves. Let's call that the door.
The door, okay.
Yeah, it's the surface where bacteria or rogue antibodies can stick and cause all sorts of problems.
Okay, so if the valves are the door, what's the muscle itself?
That's the myocardium, the thick, powerful muscle. That's the engine.
Makes sense.
When inflammation gets in there, it literally stops the engine from working properly. It causes functional failure. The pump just stops pumping.
And the final layer, the outside one?
The pericardium, that's the tough sac around the heart. We can call that the bag.
A bag.
Right. And if that bag fills up with fluid from the inflammation, it starts to squeeze the engine. It compresses the heart, and that's when things get very dangerous very fast.
Okay, that's a perfect framework. So let's start with the endocardium, the door. Here we've got two huge topics: the autoimmune reaction in rheumatic fever and the actual infection of infective endocarditis. Let's start with the immune one, rheumatic fever, which can become rheumatic heart disease or RHD.
Right. And it's important to note that acute rheumatic fever can actually hit all three layers. We call that a pancreatitis. But its really lasting legacy, its chronic problem, is the scarring and the damage to the valves. That's RHD. And what's so wild is that it's all triggered weeks after the initial infection is gone. Specifically, an untreated case of strep throat.
And the reason for that delay is it's just one of the most fascinating mechanisms in cardiology, this idea of molecular mimicry.
It's the ultimate case of mistaken identity by your immune system. Your body, it correctly creates these powerful antibodies to fight the strep bacteria's M protein.
It's doing its job.
It's doing its job perfectly. The problem is parts of that M protein look eerily similar structurally to proteins in your own heart tissue, especially cardiac myosin and the valve lining.
So the antibodies that were meant to be the heroes, they cross-react and start attacking the heart, thinking it's still the bacteria.
Exactly. The bacteria are long gone, but the friendly fire has just begun. There's no active infection in the heart. It's a pure immune assault.
And we can see the evidence under a microscope, right?
Oh, absolutely.
Yeah.
Pathologists find these really specific markers. You have the Aschoff bodies, which are these unique granulomas, and these very distinct macrophages called Inichkow cells.
The caterpillar cells.
The caterpillar cells, yeah, because of their wavy nucleus. When you see those, you know exactly what happened.
That's incredible. But for recognizing this in a person, not just in a lab, how does this systemic immune attack actually, present?
That's where the famous Jones criteria are so useful. They lay out this whole multi-system disease. The major criteria have that great acronym, JONES.
Okay, let's break that down.
So J is for joints, a migratory polyarthritis, where the pain literally jumps from, say, a knee to an elbow. O is for the heart itself, the carditis, which we've been talking about.
The little heart symbol in the acronym?
Exactly. N is for nodules, these little bumps under the skin. E is for a specific rash called erythema marginatum. And S, which is often the last to show up, is sydenham chorea, those strange, involuntary, jerky movements.
And even if all that resolves, the real tragedy is what comes later. Years down the line, that scarring on the valves leads to huge problems. Which valve gets hit the hardest?
Overwhelmingly, the mitral valve. That chronic damage typically leads to mitral stenosis, a really severe narrowing. The classic description you'll hear is the fish mouth valve, because the opening becomes this tiny, rigid slit.
Okay, let's shift gears but stay with the endocardium. So that was the immune system tragedy. Now let's talk about a direct invasion infective endocarditis, or IE.
Right. This is a totally different ballgame.
Yeah.
This is an actual infection on the valve. The key mechanism here is that microbes, usually bacteria, stick to the valve surface and they form these big, clumpy, destructive masses called vegetations.
And the speed of the infection seems to matter a lot. There's a classification for how aggressive it is.
Absolutely. We think of it as acute versus subacute. Acute is a nightmare. It's usually caused by the really nasty bug Staphylococcus aureus staph A. It's fast, it's destructive, and it can infect a perfectly healthy valve.
Okay, so that's the aggressive one. What about subacute?
Subacute is a slower burn. It's often caused by Streptococcus viridans, and it tends to infect valves that were already damaged, maybe from old rheumatic heart disease. This is the one that's classically associated with bacteria getting into the blood during, say, a dental procedure.
And we have to talk about the big risk factor that changes where the infection lands. 4V drug use?
Yes, if you're injecting drugs, the bacteria enter the venous system, so they hit the right side of the heart first. That's why IV drug use is a major risk factor for endocarditis on the tricuspid valve, the right-sided door.
Now, you said those vegetations are the core of the disease. What makes them so dangerous besides just blocking the valve?
They're friable, they're crumbly, they're just these little infected clumps waiting to break off and become emboli. And those septic emboli then fly through the bloodstream and get stuck in tiny vessels all over your body.
And that's what gives us all those classic, almost colorful clinical clues for IE.
Exactly. It's the downstream effects of those emboli.
And there are two lesions that always get confused. Can you walk us through them?
Of course. First, you have Janeway lesions. These are flat, painless, red spots on the palms and soles. They're caused by the actual septic emboli bits of bacteria and debris lodging in the skin. Painless.
Okay, painless Janeway.
Then you have Osler nodes. These are raised, tender, painful little nodules, usually on the pads of your fingers and toes. These are thought to be more of an immune reaction, immune complexes getting deposited in the vessels. So painful Osler.
Painless Janeway, painful Osler. And what about the ones under the nails?
The splinter hemorrhages, those little linear bleeds. That just completes the picture of the systemic embolization coming from the door.
Okay, amazing. Let's pull out from the valves and go deeper into the muscle. The myocardium, the engine. Now we're talking about myocarditis.
And this is a fundamentally different problem. If endocarditis is a mechanical issue, like a blocked door, myocarditis is a functional one. The engine itself is failing.
And what's scary is that the cause can be something so common.
It's terrifying. By far, the most common cause is viral. We're talking about everyday viruses like Coxsackie B, adenovirus, parvovirus B19, things that usually just give you a bad cold.
So how does a common cold virus end up wrecking the heart muscle?
It's a 1-2 punch. First, the virus can directly kill the muscle cells as it replicates. But the second punch, and often the more damaging one, is the massive immune response that follows. Your T cells rush in to fight the virus, but they cause a huge amount of collateral damage. It leads to widespread myocyte necrosis. The muscle cells just die.
And when you lose muscle cells, the engine gets weaker.
Severely weaker.
So the classic clinical picture must be pretty traumatic.
It is. The classic case is a young, healthy person who shows up with chest pain and signs of heart failure like sudden shortness of breath a week or two after having a viral illness. And their troponins, the heart muscle enzymes, are sky high.
And what's the immediate most feared risk with this? Sudden cardiac death. The inflammation makes the heart electrically unstable, and you can go into a fatal arrhythmia. The engine doesn't just sputter, it can just seize completely.
And if they survive that acute phase, the long-term outlook can still be pretty grim.
It can be. All that damage, if it becomes chronic, can lead to the heart muscle becoming weak, thin, and stretched out. And that is the very definition of dilated cardiomyopathy, or DCM. Myocarditis is the #1 cause of DCM in young people.
Wow. Okay, so that's the engine. Let's move to the final layer, the outer wrapping, the pericardium. The bag. Inflammation here is pericarditis.
And pericarditis has such a unique clinical signature. The pain is the biggest giveaway. It's sharp, it's pleuritic, meaning it hurts more when you breathe in, and this is the key. It's positional.
What do you mean by positional?
The pain is much worse when you're lying down, and it's classically relieved by sitting up and leaning forward. That's a huge clue.
Okay, that positional relief is a classic. What else do we look for?
2 big things. On exam, you can sometimes hear this scratchy grating sound called a pericardial friction rub. And on the ECG, the hallmark is diffuse ST segment elevation pretty much everywhere.
Now, I noticed the most common cause is, again, viral. Coxsackie B comes up again.
It does. But there are other important causes to remember. Post-heart attack inflammation, which we call Dressler syndrome, autoimmune diseases like lupus. And in some parts of the world, tuberculosis or TB is a really major cause of chronic pericarditis.
So the bag gets inflamed and it starts to leak fluid. This is the pericardial effusion. And if that fluid builds up too fast,
That's where the real trouble starts.
That's where it becomes an emergency. The effusion itself is just fluid, but when that fluid starts to crush the heart, that's when you get the life-threatening complication. Cardiac tamponade.
And we should be really clear here, tamponade isn't just bad pericarditis, it's a mechanical shutdown of the heart.
That is the core concept. It's about pressure, not inflammation. And the most important point is that the rate of fluid accumulation matters more than the total amount.
How so?
Well, if fluid builds up slowly over weeks, the pericardial bag can stretch to hold maybe a liter or more. But if trauma causes just 200 milliliters of blood to gush in there suddenly, that can be instantly fatal because the pressure spikes immediately.
So what is that pressure actually doing to the heart, mechanically?
It's squeezing it from the outside. The right-sided chambers, the right atrium and ventricle, are weaker, so they collapse first. They can't fill with blood during diastole, and if the heart can't fill, it can't pump. Cardiac output plummets, and you go into obstructive shock. The key hemodynamic finding is an equalization of diastolic pressures in all four chambers, because that external pressure is limiting everyone equally.
So how does this collapse show up at the bedside?
You look for the classic signs known as Beck's triad. It's three things. 1, hypotension, so low blood pressure. 2, jugular venous distension, or JVD, because the blood is backing up. And 3, muffled heart sounds, because you're listening through a bag of fluid.
And there's one more physical sign that is just textbook for tamponade?
Ah, yes, pulsus paradoxus.
It sounds like a contradiction. Explain
Yeah.
that one.
Right. So normally when you breathe in, the right side of your heart fills a little more. In tamponade, the heart is already squished. So when you inhale and the right ventricle expands that tiny dip because the bag can't stretch, it shoves the septum over to the left.
Ah,
And that dramatically crushes the left ventricle so it can't fill properly. The result is a big, measurable drop in your systolic blood pressure, more than 10 points, just from breathing in.
that is a brilliant sign. And on the ECG?
You might see electrical Hall turn-ins. The heart is literally swinging back and forth of the fluid, so the height of the QRS complex alternates from beat to beat.
And the solution isn't a drug, it's a procedure.
Exactly.
Yeah.
This is a plumbing problem. You have to drain the fluid urgently. A procedure called pericardiocentesis.
That was an incredible tour from the inside out, from the structure to the emergency. We started at the door with rheumatic fever's molecular mimicry and infective endocarditis' microbial vegetations, and those classic signs like Osler notes.
Then we went to the engine myocarditis, driven by viruses like Coxsackie B, leading to arrhythmias and long-term dilated cardiomyopathy. And we finished with the bag, pericarditis, with its positional pain and friction rub, and its ultimate emergency, tamponade, which you diagnose with Beck's triad and pulsus paradoxus.
When you step back and look at all of this, a major theme seems to be the timeline, how these acute, common events can lead to severe, lifelong disease.
It's truly humbling to think about. A patient with severe mitral stenosis today might be living with the consequences of an untreated strep throat from when they were a child. The person getting a heart transplant for DCM might trace it all back to a bad cold they had last year.
Right.
Acute inflammation, if it's not managed, can permanently change the structure of the heart.
So if these seemingly minor infections can lay the foundation for catastrophic heart disease decades later, what does that tell you? What does that say about the deep connection between our immune system and our heart, and maybe the critical importance of primary care, of taking even those minor illnesses seriously? That is something to keep in mind. Thank you for joining us for this deep dive.